Good evening, everyone. Hi, my name is Lakeisha Williams. Our group conducted our research on Access Health. I am actually the Director of Executive Operations of the organization and kind of just wanted to start off with a brief overview of the organization and what exactly we do here at Access Health. So, Access Health is actually a nonprofit healthcare provider here in the Houston, Texas area. Our mission is Access Health is dedicated to excellence in providing integrated healthcare services to improve the quality of life in the community it serves. So, some of you might be unfamiliar with the phrase integrated healthcare, so I'm going to dig just a little bit deeper on that on the next slide. So here you'll see an integrated care model. This is pretty much a good diagram that sums up the services that we offer here at Access Health. And integrated healthcare is pretty much offering multiple healthcare services underneath the same roof and within the same EHR system. So offering integrated healthcare system allows our families to do multiple things. So say for instance, a pregnant mother has a sick 2-year-old, maybe just a cough. So while she brings that child in for their pediatric appointment for the cough, she could also be seen for a 36-week OB-GYN appointment. The reason why this is so important is because being that 99% of our patients we serve actually have a household income at or below the 200% federal poverty level. So a lot of those often have barriers to access to healthcare, hence our name, Access Health. So an example, they could have issues with maybe transportation, maybe they don't have a vehicle, or they could have a vehicle, maybe they just don't have the gas money to make multiple trips to maybe the PD clinic and then to the OB-GYN office. Same thing with work hours. A lot of our patients work more than one job, so maybe they just don't have the flexibility of their work schedule to come in during a typical business hours. And we do offer extended hours. We're open from 7 to 7 at 2 of our main medical locations, and we also are open on Saturdays, which makes it really convenient for our hardworking parents. So having a one-stop shop is truly a bigger blessing to our patients than one could really imagine. Also, let's see, in our integrated model, we offer the following services currently. So as we're looking at this schedule here, primary health care, which is kind of what you normally would see. That includes family practice and pediatrics. You have your OB-GYN, so this would be prenatal care. We also do deliveries at the hospital. We do have Class A and Class D pharmacies on site. This is really, really big with our patients. I personally know myself. It makes it so much more convenient to be able to finish out a doctor's appointment and your doctor, instead of saying, what pharmacy do you have? You can literally just have them send it right over, walk down the hallway and just pick up your prescription. Love it. We also have a 340B discounted prescription program. So that's another plus. But like I said, really just having it on site, it kind of really eliminates like the driving and having to drop it off, come back in an hour, that kind of thing. So again, an integrated care model. Even going further, we specialize in behavioral health as well as HIV and substance abuse. We do have dental at 2 of our main locations, nutrition, laboratory. This also very similar to pharmacy, is very, very, very convenient for the patients to be able to see the doctor and the doctor say, okay, we need to do blood work, and they're able to literally just go 2 doors down, go get the blood drawn and just walk away. Women, Infant, and Children Nutrition Services. This is formerly known as WIC. We do offer that also on site. So like I said, this pretty much sums up our integrated care model, and it really tells you kind of what all we do here. So on this slide, I'll kind of dig just a little bit deeper on our patient profile so you kind of get an idea of the patients that we serve here in the community at Access Health. So in 2018 already, I know the year hasn't quite ended yet, but we have already seen over 19,000 unduplicated patients at our 5 medical sites, which is amazing. As I kind of briefly touched on earlier, 99% of our patients that we do see have a household income at or below 200% of the federal poverty level. With that, we also take all insurances. We don't turn anyone away. So here on this next tab, you'll see 50% of our patients are actually uninsured. So we do have a sliding fee scale discount that's based on household income. We work with our patients. The copay are between $10 and $40, but again, we turn no one away. So even the patients that might have a copay of $10, we still kind of just write it off. 30% of our patients have Medicaid or CHIP. 10% are private and 3% are Medicaid. So again, with these Medicaid, CHIP, Medicare, these federal and state funders that we have. We do follow strict guidelines. We have to meet measures, data measures, and that kind of thing. And we'll kind of dig deeper into that later. 85% of our patients are minorities, and 6% are female, and 40% are male. So as you kind of look at this slide, you can kind of get the idea of the polarized nature of Fort Bend County and how it's reflected in our patient population. And of course, I'm going to dig deeper about Fort Bend County. I know some people are like, what? All we know is Cumberland, but I'm going to dig a little bit deeper in Fort Bend County here in Houston, Texas. So, as promised, I'm going to speak a little bit more about Fort Bend County. I know Fort Bend County kind of doesn't really register with any of you guys over there in North Carolina, but like I said, I live here in Houston. So, the county that we do reside in is Fort Bend County. And fun fact, it is actually the most diverse county in the United States. And I kid you not, on the first day that you guys will walk around here, you would easily see that. And our patient population shows the exact same thing. It's also the fifth fastest growing county in the United States. It is the sixth healthiest county in Texas. And so currently our population is around 750,000, and it is actually projected to reach 1 million in the next 2 years, which is kind of crazy. That goes back to the fifth fastest growing county. So 70% of the county is undeveloped. So as you guys kind of look at this map, again, I know you guys aren't kind of familiar with the cities and the towns that are here, but as you look to the east, that would be Houston. And so we're looking at Kendleton, Beasley, Neeville, the stuff further to the west, and these are very rural areas. So while this is a fairly large and growing and diverse county, it's very limited access to healthcare. So that's really what our mission is to really offer quality healthcare to those in need. So also 20% of the community actually qualifies for our sliding fee scale. And again, this goes back to the 99% that is at or below the federal poverty level of 200%. So now that we've gone over what Access Health does, for whom we do it for, now you'll kind of see here how we do it. So here we have our operations, basically, or how we fund what we do. So we have local government grants, we have our patient service revenue, which is pretty much like those insured patients, the co-pays, same thing for the uninsured, that sliding scale fee that they pay, those kind of things. We also have state grants, so this will be like your WIC program. Private foundation support, these are private funders that fund us just based off the work that we do, for us being known, brand awareness in the community, and them actually physically seeing like the work or the programs or the projects that we're putting out in the community. So they decide to actually privately fund us. Fundraising events. So not only do we offer healthcare for our patients, but we are very big in our community. We want to be out there and support our patients, not only just our patients, but just our community in itself. So to the right, you see a couple pictures from a few events we have. So the top one is actually our community operation, and that is our health fair. So we do 2 of these right before the school year, 2 different locations, and just a big location that's open to the public, and we offer free backpacks, school supplies, haircuts, immunizations, physicals, eye and vision screenings. I mean, anything that you can think of. But it's such a big turnout. We give so many backpacks and school supplies away. We have free snacks and activities for the kids, such as rock climbing. It's just a really fun day to come out, and it's really, really helpful in the community. We've gotten so much great feedback from them. At the bottom picture, these are some of our expecting mothers. So another thing that we do, we have baby showers, and we do those quarterly. And these again are open to women, pregnant women, patients, and open to the public that are either in their 3rd trimester or just recently had a newborn within the past month. And again, it's just a baby shower. We give away many gifts, coupons, discounts, referrals, just a lot of good stuff. It's a fun time. We do cake, anything that you would typically see at your typical baby shower. Last but not least is our federal grants. This is really big. These are grants that we get through the federal government, and the way we get these are pretty much based off the measures of the work that we do. So the unduplicated encounters and meaningful use and things of that sort. And this is kind of where we kind of drove most of our research, because based off this data and the measures, we wouldn't be able to get a large amount of our funding that we do from federal grants.
As we began to further understand the background and goals of Access Health, our client, we really wanted to define the problem by breaking it down into three sections. The first section was organizational costs, the second being patient portal enrollment, and the third being the provider's productivity overall. In this first section, the real nature of the problem was that absenteeism or no shows for scheduled appointments was driving more cost for the organization. Because their goal was to serve the community at the best of their ability, certainly minimizing costs was a big part of their strategic plan. Secondly, they were very interested in increasing their patient portal enrollment. However, due to the nature of their service area and the types of clients they were providing these healthcare services to, unfortunately, getting them to enroll for the portal was a problem. Many of them had restrictions due to their economic backgrounds or just disinterested overall from an untrusting nature, being unfamiliar with the technology and wanting to ensure their privacy was upheld to the utmost of their ability. So this created an issue as well, since the portal's purpose was to provide more instantaneous access and be more convenient so clients could reschedule appointments if needed. Lastly, the problem that Access Health faced was their provider's productivity was limited due to these no-shows and absenteeism. When these schedules are created and clients are expected to come in, or patients rather are expected to come in, when they don't show up, the provider no longer is able to maximize the use of their time and has to rearrange their day, causing other logistical issues for the clinic. Obviously, these are problems that hinder the organization overall, so addressing this absenteeism and identifying any means they have available to minimize it is very valuable to them as a whole.
We hypothesize that the probability of an appointment missed by a patient may be explained by a number of variables. Our sample was comprised of 215 scheduled appointments whose data included our target variable, which was whether a patient was absent from or present for a scheduled appointment, and our explanatory variables, which included the patient's doctor, whether they were visiting pediatrics or the family practice department, whether the appointment was scheduled for the morning or afternoon, whether it was a first-time visit versus otherwise, and finally whether the patient was or was not enrolled in the online patient portal. We first created a cross-tabulation table using SAS software. By creating the cross-tabulation table and using Pearson chi-square association with all other variables against the present versus absent variable, we were able to determine that the only variable with any significant association occurred with the online portal participating versus not participating variable. With a p-value well below 0.05, this was the only variable that would allow for the rejection of the null hypothesis. By examining the relative chi-square test statistics, all other variables exhibited p-values significantly greater than 0.05. The next closest variable was the morning versus afternoon appointment, and its p-value measured over 0.35. After disregarding the other variables, we then focused on the chi-square association between these two variables. The cross-tabulation table showed a significant difference between what should have been expected and what actually happened. Taking into consideration all possible combinations, around 14 of those who were not participating in the online portal were expected to be absent for their appointment. However, the actual count was 26 patients. Those who were actually present and not participating in the online portal were significantly less than what was expected. This was almost 70 expected patients versus only 58 who actually showed up. Those participating were also more likely to show up to their scheduled appointment. Expected absences were almost 23 patients, but only 11 patients missed their appointments. Also, only 109 patients were expected to be present, 120 patients actually showed up. Again, the p-values for the chi-square test statistics exhibited statistical significance. However, the Kramer's V only measured 0.2916, which shows a relatively low measure of strength of association. We then ran a binary logistic regression with the present versus absent variable as a response that would be predicted by the other aforementioned variables. Unfortunately, the only variable that provided any statistical significance for predicting whether a patient would be absent or present for an appointment was with enrollment on the patient portal. With a significance level above 0.05, all other variables' p-values did not provide the required level of statistical significance. This was made evident by the systematic removal of the other variables by using the backward selection regression model. Next, we attempted a forward selection regression model, and then finally a stepwise regression model, which both provided the same outcome as the backward selection regression model. Still, by including the patient portal variable, we were able to reject the null hypothesis and show that the effect was significantly different from zero. By again using SAS software, we were provided with a great deal of analytical data. The model information table provides general information including the name of the dataset, present versus absent as a response variable, 2 as a number of response levels, binary logit as a model type, and Fisher scoring as the optimization technique. The next table shows that 215 observations were read and used. The response profile table shows present versus absent as our dependent variable and its relative frequency, with 37 observations being absent and 178 being present. The class level information table identifies patient portal as our predictor variable. The model convergence status table indicates that our convergence criteria was indeed satisfied. The model fit statistic table includes 3 goodness of fit measures that are used when comparing multiple models. Since the other variables are not statistically significant, this table was not applied. The testing global null hypothesis beta equals 0 table provides 3 statistics to see whether there is at least one coefficient that is different from 0. The likelihood ratio is generally considered the most reliable, however all 3 statistics do show this difference. This table also tells us that there is 1 degree of freedom and that we can indeed reject the null hypothesis. The Type 3 analysis of effects table provides the Wald chi-square and p-values of each descriptor variable. This again shows that patient portal does have statistical significance. The analysis of maximum likelihood estimates table shows the estimated model parameters, their relative standard errors, Wald chi-square values, and their p-values. The odds ratio estimates table shows that a patient is 20.5% more likely to attend a scheduled appointment if they are on the patient portal versus not enrolled. It is also considered statistically significant since its 95% Wald confidence limit excludes 1. Finally, the association of predicted probabilities and observed responses table provides another test for goodness of fit. Although the percent tied is relatively high, the percent concordant is slightly higher at 47.4%, and the percent discordant is significantly lower at only 9.7%. The concordance statistic is measured at 0.688, which shows a strong ability of patient portal to discriminate between patients showing up for appointments or being absent.
When we originally attempted this project, we had a different idea for our methodology, and by changing the methodology, we got different results than what we had originally anticipated. Nevertheless, we were very happy with the results that we got and were able to provide some insight to the clients, Access Health, in order to help them streamline some of their efforts and focus on how to better utilize their portal to address the issue of absenteeism. Our results and analysis showed that there really was no relationship or correlation between the various variables we considered for this study. The only thing that we were able to identify, fortunately, was that patients who were enrolled on the online portal were more likely to be present for a scheduled appointment. Therefore, noticing this probability, they, as an organization, can focus their efforts and their strategic plan on increasing enrollment overall for the portal. And that will be their best option to minimize the absenteeism and address the challenges that were previously discussed under our problem definition. In our initial plan, we wanted to use optimization modeling to improve attendance probability. But unfortunately, it wasn't possible since we only had one statistically significant categorical variable. This relationship does provide some implications, but it is limited, and more testing would need to be conducted with more data in order to have a stronger strategy or recommendation in place. In conclusion, our research conducted for Access Health reviewed several variables as it relates to the patient portal and their no-shows for morning appointments. Unfortunately, the variables that we reviewed did not show any significant association. However, we were able to uncover that a person being enrolled in the portal or having access to it did show less likelihood of not showing up for their scheduled appointments. Now, while the portal has many functions and its purpose is valuable to the healthcare provider, ultimately, further research should be concluded to focus on optimizing their scheduling. Other variables that they might want to consider may include the patient's age, income level, and living proximity to the healthcare center. Access Health should continue to evaluate current markets for promoting the patient portal. It seems that if they were able to increase their enrollment, then they would see some sort of decline in their overall absenteeism for no-shows on appointments. We were very grateful to be able to do this research on behalf of this MBA program for our client, and we hope that it is of value to them as they continue to work to streamline their systems and processes and enhance the value they are able to give to their community. Again, it has been a pleasure for us to take this opportunity to use what we've learned in this business analytic course to apply it in a real life scenario. My team and I really enjoyed the process of exploring and getting to know how these skills are applicable in the real world and how they can help organizations make better, more suitable business decisions as they work to carry out their strategic plans. Myself, Maybelline Rodriguez Laureano, and my teammates Matthew Rogers, Sylvia Hodges, and Lakeisha Williams, thank you for your time, and if you have any questions, please feel free to let us know.